All right, well, I think I'll go ahead and get started. Um, Someone let me know if we're not looking at opioid use disorder for the astute provider. But I will leave the group chat open. Should you have questions that you need to type to me as we're going along, probably will be easier than trying to break in and ask questions, and that also will allow us to possibly answer some things in real time if need be, rather than wait until the very end. Today we're going to talk about opioid use disorders, and I think it's pertinent, as I understand that everyone there is doing the training to be DATA 2000 waivered. We'll explore reasons why we should be focusing on treatment of opioid use disorders primarily, and we'll give you an opportunity to kind of see the history of this treatment as it goes. For those of you who do not know me, I guess I should introduce myself. I am Ryan Brown. I'm a family physician by training. I was an associate director at the program until July, when I transitioned to a role here, mostly doing inpatient medicine, where I do addiction medicine consults as my clinical time. I'm also the medical director of our inpatient or our intensive outpatient programming, both here and at Jay, and then also developing the footprint for addiction medicine here in East Central region. I do not have financial interests other than the fact that I am associated with IU Health. Trade names, brand names, and company names will be mentioned potentially in this talk. These are not endorsements of those companies or those products. They are just what we have available to us. And then a number of these slides are adapted or are used directly as shared educational products of the ASAM. Some of them will be watermarked as such. Learning objectives today, really just the historical significance, the basis of medication-assisted treatment, how it fits into the addiction model. I want people to be confident in their ability to treat some of the syndromes that we see associated with opioids, and understand the unique properties of some of the things that we can use to treat opioid use disorder, so that no one feels limited in any way in what they're doing to do treatment. Brief epidemiology and history. These are things that hopefully you've seen many times in the past. If any of this is new to you, then pay attention, because I really won't say many things twice. We'll just kind of roll through fairly quickly. As you know, opioid overdose deaths have been on the rise for quite some time. So I don't know that it's an indictment of my particular medical education, but it seems to have started as I graduated and continuing to worsen. So possibly I'm part of that problem. But more recently, what we've seen are synthetic opioids with fentanyl, carfentanil and the such, starting to create some of the largest influx of opioid deaths overall, or not just deaths, but opioid overdose, with people surviving those as well. And a lot of times those are a mixed product with other substances. Here again, we're looking at opioid deaths called drug poisonings. So as you see in 2002, when I was just starting my second year of medical school, the climate and landscape was quite a bit different. Here we see Appalachia. This is Nye County in Nevada, where there's still legal prostitution. Not a lot of people out there. I'm not sure why it pops up as a bad area, but we see a lot of the West had kind of a moderate age-adjusted death rate compared to the rest of the U.S. And then the rest of the U.S. Not only caught up, but we start to see quite a bit of spread from Appalachia out and around, and that's what concerns us here. And of course, out west is significant as well. I'm going to revisit this slide a little bit later, but I wanted to show you the 3 opioid addicted cohorts that are pretty well described in the literature. That 20 to 40-year-old age group with significant heroin use, and this makes sense. The 18 to 24-year-old age group is actually the ones who have the highest use of illicit drug use and experimentation, and they tend to go from opioid prescription use to significant heroin use. The 40-year-olds and up, and some of these probably still linger around your clinic to some degree, are disproportionately white. They've mostly used prescription opioids, and they continue to use prescription opioids that create their addiction. And a lot of the problem with them is, as the CDC has changed guidelines for pain treatment and such, they've just been cut off cold turkey, and so their addiction has become significantly more dangerous for them. 50-year-old and up has disproportionately been non-white. They started as heroin users and continue to be heroin users. The history of opium, we'll just discover real quickly, starts in 3400 BC as the earliest recorded, where we see some of these carvings around and about areas of Mesopotamia where opium grew very nicely. In 1839, we have documented first opium wars, and so where Britain was selling opium to the Chinese, and the Chinese emperor discovered that the addictions were becoming a significant issue there, embargoed any sales into their country, rounded up all the opium and destroyed it. So that created those wars between Britain and England, which ultimately resulted in China paying a big indemnity and giving them Hong Kong. So those of you who maybe are not up on your current events in regards to all the issues with Hong Kong, of course, it was given back from Britain to the Chinese, and now the Chinese are trying to reinforce their rule over Hong Kong, which feels it's independent. This, of course, is a Bayer product from 1898. So they not only made aspirin, but they found that aspirin didn't treat everything, and so they ventured into heroin. So anyone who thinks Purdue Pharma is an evil drug company and everybody else has done well, this is actually Bayer here producing heroin, which they originally marketed to doctors only. And they said it was a non-addictive treatment that you could add for cough medicine because, as it proved, codeine was addictive. As we know, that was probably not the case. Heroin seems to be very addictive. In 1935, the U.S. took a jump into treatment, and as you can see here, public enlightenment was the result as we created the first federal narcotics farm where opiate addicts or addicts of all types could check themselves into the same federal penitentiary in Lexington, Kentucky that housed violent criminals, and they could pursue drug addiction at the same time. Of course, it was abstinence only and hard work to try to beat it out of you, and what they found is that they had about 90% recidivism with anybody who had an opioid use disorder. So these are some very boring slides, but I'm going to run through them very quickly just to kind of see in 1905 what our government has done and how it leads to all of you getting data 2000 waivers from a law that was created in 2000. Opium was banned in 1905, and then medications began to need to be labeled in 1906. Harrison Narcotics Act was something that was created to standardized use of both opium and coca products. Specifically, cocaine was being used in Coca-Cola. Opium products, of course, morphine and codeine had been around for quite some time. Heroin was falling out of favor in regards to use, but morphine was being used to treat people who had an opium or laudanum addiction by physicians. And what ended up happening is about 25,000 physicians who were treating addiction as a disease at that time had been rounded up, and about 10% of them ended up going to jail in trying to treat addiction as a disease, because the United States by far had interpreted at that point as addiction a moral failing. Supreme Court sided with that. The physicians stayed in jail, and about 10 years later they went back and said, well, we shouldn't have told physicians how they can run their practices, and so a lot of that was reversed. It wasn't until 1970 that we created the DEA to control a lot of these scheduled products, but again, it became political instead of medical as they obviously put scheduling numbers on a number of different products, but then left tobacco and alcohol as legal products to be sold, whereas things like marijuana were put in the same schedule as cocaine. So all of that was very much politically motivated, and very little of it had to do with public health measures and research that we knew. In 1974, for the first time, we had a law that allowed methadone to be used to treat opioid addiction. And then the Data 2000 waivers opened that up to a lot more physicians if they could be waivered, as long as they also had the capacity to refer patients for counseling for their drug treatments. So our lessons from history up to this point have been that addiction is an ever-present phenomenon, dating way, way back. If we look at alcohol, the Chinese knew that alcohol was a problem 10,000 years ago. It is a changing focus from time to time on different substances and the behaviors associated with it. Treatment has focused over the years on religious conversion, which failed, psychoanalysis with Freud, which failed, characterological manipulation, which was our federal narcotics farms and beating it out of you and changing you completely, which failed. Legal interdiction was then a reversal of that, saying, well, let's throw people in jail and see if that works. We know that that failed. But it's still happening. And then pharmaceutical intervention is helpful, and it's something that, which is the point of this talk. However, by itself, it fails. Short-term interventions do not work, so we must treat addiction as chronic long-term care. And the illness, of course, is very complex. And each individual patient must be treated as an individual, and thinking through each particular care plan in the long term for these patients. So they do present quite a puzzle, and so a full day's work may just be thinking about 4 different patients. So a brief look at the science, and this will be a very brief look at the science, but anyone who is interested, this might be something that we can have a lecture on, a little bit larger lecture in the future. But this gets into the classes of receptors that the opioids do touch. Mu opioid receptor is the one that we probably will speak about the most today. That is what all of the known opioids that we know do activate. Endorphin is the protein inside of the body that signals it. Kappa opioid receptors are also an analgesic. So mu and kappa are both responsible for the analgesia that we feel from the opioids. The kappa receptors are the ones that are, I guess, activated by things like butorphanol. So anybody who's used Nubain here before, that's also one of those, pentazocin. And then we know a little bit about the delta opioid receptors. These are the ones that have some mood enhancement along with the kappa opioid receptors. And delta is an interesting one that we don't know as much about right now, but buprenorphine, which we're going to talk about in a little bit more depth today, actually is an antagonist at the delta opioid receptor. And one of the reasons we're starting to think that it might have a little bit more effectivity in regards to the treatment of opioid use disorders over what they used to try in the early 20th century there with morphine. This is a slide that really I just put on here to show you where the mu opioid receptor concentrations are, but they are throughout the body. This is just looking at the analgesic properties of the mu opioid receptors, and you see where they mediate a lot of the particular function inside of the midbrain there with the thalamus, the caudate, the nucleus accumbens, the amygdala, and then they are through the spinal cord there as well. A quick word about opioid activity levels, since we'll talk about methadone, buprenorphine, and naltrexone. Methadone is a full agonist, just as most of the opioids that we use for pain management are. That full agonist fills 100% of the mu receptor and creates fills the mu receptor and creates 100% intrinsic activity from the mu receptor. Buprenorphine, if you've heard it described as a partial agonist, that basically means that it fills the receptors. However, it only creates a certain percentage of activity, no matter how much we give. And so that's often referred to as that ceiling effect. And then the antagonist naltrexone, of course, just blocks the mu receptor activity completely. Not much to say here other than the fact that the endorphin systems, those mu opioid receptor systems, are throughout the entire body, which creates some of the effects that we see both in withdrawal, but also some of the side effects that we see when we treat people with opioid pain medications. And I'll just list a few of those here. We know that sedation, analgesia, and euphoria are the things that not only our patients are looking for, but that we benefit from as physicians when we are using these medications. But we can't forget about constipation, constipation being one of the most prevalent side effects of opioids, and then nausea for some patients who cannot tolerate opioid pain medications. Of course, we had decreased testosterone, increased prolactin, changes to FSH and LH, can create urinary retention issues. Cardiovascular systems, we see vasodilation, prolonged QTC, which is a problem with methadone primarily. Meiosis is the pinpoint pupils. I put here that tolerance varies. The reason we have to be concerned about tolerance varying is that we know that the euphoria tolerance develops very quickly. So that patient that uses for the first time and the second time never gets back to that same euphoria that they did with that very first use. Analgesia is something that over time patients will get less and less analgesia. So anyone who prescribes opioids for pain medication knows that the patients eventually will get to a point where they say, well, these just aren't working as well for me. And sedation. So sedation will decrease. This is the reason that a patient can use 1 gram, 2 grams of heroin a day and not kill themselves, because over time they can work themselves up to that tolerance on the sedation. However, we also know that constipation does not work in the same way, and there's no tolerance to constipation. So be merciful for your patients, anybody that you give opioids to, including if you're treating an opioid use disorder with buprenorphine. Think about constipation, ask them about it, and figure out how you can keep them regular. As people withdraw, a lot of times what we'll see is that that the tolerance will reverse in regards to sedation and analgesia, and so be very careful in regards to what you are doing even a week or 2 weeks out from someone who was a heavy user, very significantly, or could have very significant sedation issues, even in starting something for their use disorder like methadone, if they're going to an OTP or you're starting it in the hospital. A word about potency. We know that morphine, if we use that as the relative potency of 1, it goes up from there. Heroin is about 2 times more potent. And so potency is that effect or getting desired effect. Fentanyl is about 100 times more potent than morphine. And then more recently, we've started to see sufentanil and carfentanil popping up. These are very dangerous drugs because, as you can see here, an approximation of what that lethal dose is. These are very small amounts. Again, it is very rare for someone to come in having a use disorder with fentanyl or, of course, anything more potent than that because you're using such small quantities. And usually these are things that are mixed in with other substances. Or what a lot of our patients are starting to find is they're mixed in with what is essentially a bag of talcum or pressed into pills, and very little of it is any sort of a product. Just to show you that this is real, this is from Columbus last December, I believe, last November. And what I've circled, there on the screen is carfentanil. The people that they arrested and got this from did not even realize that that was the product. What you're looking at is about 25 grams of carfentanil, which is enough to kill 1 million people. It's a lethal dose for about 1 million people there, that one baggie. Pharmacokinetics of opioid use. This is just important anytime you're asking the history of how someone uses opioids. There are things that get to the brain a lot quicker. Obviously, if you smoke it, it's going to get there through the lungs, dissolved in and straight up to the brain quite a bit quicker. Intravenous is just a few seconds behind that. It's just that the pulmonary system is better at absorbing and directing straight to the brain rather than sticking it into a vein where it has a little bit more space to travel. Intranasal, this is the reason that people snort. It does get to the brain and the system quite a bit quicker than if you're just swallowing those orally, and then transdermal, of course, is a very slow and steady gradual increase. So that might be the reason that, that people use for different reasons. The other thing that you'll find is that someone who uses orally or uses intranasally will often be able to be controlled quite a bit easier in regards to pain, in regards to their effects that they get from opioids than someone who smokes or uses intravenously. And I'm sure you've all had patients in the hospital that have significant pain issues with osteomyelitis, and they're very hard to control because they're intravenous users. So let's get into clinical context, which is why the vast majority of you are probably here. And I want to talk about opioid overdose. I think that we'd do ourselves a disservice if we didn't recognize, you know, the classic triad seen in opioid overdose. That's meiosis, the pinpoint pupils. It's the decreased level of consciousness and respiratory depression. Because this is so prevalent in our community, a lot of our first responders will have naloxone with them. They will give naloxone to anyone who is demonstrating these particular signs. You'll see sometimes a patient with seizures will have been given naloxone just in case. And so there's a lot of deployment of naloxone in our community. And the reason is because a lot of these people fit a portion of that classic triad, and it would be foolish for us to miss a potential overdose that we could reverse with that particular medication. But the triad is the first three. Pulmonary edema is one of the things that becomes very problematic for people who overdose. If they overdose outside of the hospital, sometimes these are the ones who don't come back very easily with naloxone and may end up as an overdose death, even though they had the appropriate equipment. And then seizures are more commonly seen with meperidine, which is the old Demerol, which isn't used very much, and then tramadol. So be very careful in giving tramadol. Just a very quick word about opioid overdose, since you all do go through the emergency department, and this may be something that you'll see. There's a lot of different ways to approach this, but I think a fairly standard way that I think I borrowed most of this from UpToDate, but of course ventilatory support is what we're looking for. There's option to give IM or IV in the emergency, or even intranasal. All of those do work. If you have IV access, bolusing that until adequate ventilation. So yes, we do see people go into withdrawal. We do see people become more alert, but really adequate ventilation is the key thing that we're looking for, and that drives us for treating with naloxone. And it's the key thing we're looking at or watching. 5 to 10 milligrams of naloxone infused without signs of opioid withdrawal, without signs of this person improving, you might have the wrong diagnosis. That's really the only reason I put that on there. And then there's a way to continue bolusing, and or if no IV access, then 0.4 to 0.8 sub-Q or IM, and observe them, because respiratory depression does recur with the fentanyl. That is because it's very potent. Sometimes that can cause the recurrence, or someone who is using longer acting types of medications, methadone, for example, or some of those extended release opiates may have recurring respiratory depression even after they've been treated once or twice. And so this is the reason I'm just putting that up there for you to kind of have in the back of your head. The pitfalls of, and maybe this is some of what I just said, but repeated naloxone prescriptions with longer acting opioids and more potent opioids. This is the reason that our standard, I think, in Cerner, if you order naloxone for someone, is they give people 2 kits instead of 1. Check for the fentanyl patch under the clothing. So if you're looking at a patient that has a chronic pain disorder or or maybe you're being treated for terminal cancer pain. They might have fentanyl patches on, and oftentimes they will. Anyone who injects fentanyl, they can get a chest wall rigidity, skeletal muscle rigidity, and so sometimes they can be very hard to bag mask, and so it's important to make sure that we're thinking through all the different pitfalls in regards to ventilation with these patients. Be alert of other possible acetaminophen if someone's using Vicodin or Percocet. And don't forget about safe discharges. So just because someone has been resuscitated, revived from their overdose, when they are discharged from the emergency department, we really need to be thinking about what does that mean then for the next couple days, for the triggers that they're going to have. And so I put this up here because the emergency department is one of the places where the law does allow initiation of buprenorphine. And there's a couple different ways to go about it. The COWS scale is going to give us their opioid withdrawal. And so if they have a mild withdrawal, they don't necessarily need dosing in the ED, but they either need a provider who is buprenorphine waivered, so that they can prescribe to that person maybe about a 3-day script with time to get to that next level of care. So one of the OBOTs here in town, which are the opioid-based or outpatient treatment, or the Muncie Comprehensive Treatment Center, which is the methadone clinic. Those are, or even if you're a prescriber yourself, to get them back to your particular office in order to continue prescribing for someone. This is a harm reduction technique, and we know that we can save lives if we continue prescribing for someone who has had an opioid overdose. The other option, this is what we usually talk about, is a 72-hour rule. When someone is treated inside of the ER, they are treated for their withdrawal, started on buprenorphine, and then they can return for the next 2 days and be continued on buprenorphine. And so if someone is not an opioid prescriber, they can still bring that patient back to the ER 2 days in a row, 2 more days in a row, treat them for 3 days, again, as they're trying to get that referral going for ongoing treatment. So that is that 72-hour rule, if you've heard about that before. Clinical opiate withdrawal scale, again, this COWS scale is something that you should get to know pretty well. It is something that a lot of what we're doing in regards to treating opioid withdrawal, it starts at, what is the COWS scale? What are some of those objective and subjective measures of particular patient's issues? So everything from sweating to tremors, yawning, pupil size. They'll start with muscle and aches and things like that. And so just a word about opioid withdrawal. Very early on, we'll see the pupils start to dilate. We'll see excessive sweating, tearing, anxiety will become significant. They'll start to have muscle aches, complain of a lot of pain. Think about those patients in the hospital that you're seeing early on that have significant pain issues related to their substance use. We'll start to see some of those adrenergic effects as the opioids are now 24 hours out of their system. And that's the nausea, vomiting, the heart rate changes. And then as we get to 2 days, 3 days out, that's usually the peak of the withdrawal symptoms, especially the more common heroin withdrawal, where they start to get severe drug cravings. Their mood instability is at a peak. Often these patients are leaving AMA at this point because they feel so poorly, and they know that they can chase away the withdrawal, the dope sickness, by going back to injection use. And so if we are not doing our best to treat withdrawal symptoms at that point, then these patients are very high risk for elopement. Just to give you an idea of withdrawal, because we are talking about using buprenorphine and methadone, there are patients that elope from our treatment, and so they just won't show up, or there may even be cases where we tell patients we can no longer treat them because of diversion or other risk factors. And so for that particular patient, they can have a little bit more extended withdrawal. The withdrawal symptoms don't hit the severity that's something that is more lipophilic, like a heroin or a fentanyl might give them, but they can be they can extend quite a bit longer. And methadone, anyone who has had a patient who was in a methadone clinic or misusing methadone on the street and then decided that they were quitting cold turkey, they will describe to you how miserable they were for about 30 days with that. So some of the withdrawal treatments, I think a lot of people are familiar with symptomatic treatment. The third bullet here, thinking about NSAIDs, Imodium for people with diarrhea, the benzodiazepines may be helpful early on in regards to mood instability, but certainly not something that we want to use a lot of. And ideally something that we would keep to the oral formulation, because the IV formulation of any of these particular medications, it can give some sort of a feeling a rush in regards to the way that they're used and how quickly you hit the brain. So think about that as with your antiemetics as well. And then clonidine helps with those adrenergic symptoms. Things that I don't see used quite as often, but are still within our bag of tricks: methadone, although that's something that I use a little bit more often and maybe should be left to addiction medicine. But it is something that you can prescribe for someone who is hospitalized, especially if they're already in a methadone clinic. Just verify the dose. If we can't verify that dose, then start them about 30 milligrams. It'll be better than allowing them to withdraw significantly from their methadone use and then figure out that dose later so that we can bump that up. And then buprenorphine is something and can be used very successfully with these patients that are hospitalized. And can be used to treat their withdrawal symptoms. We always get concerned about precipitated withdrawal. I'll say something about that in a moment, but when someone is in significant withdrawal, that CAL score is greater than 8, greater than 10, greater than 12 for sure. We know that it would be very safe to start buprenorphine with them, or if they are being discharged or in your outpatient clinic and they're withdrawing, if you are waivered, you can give them buprenorphine to kind of help with those withdrawal symptoms. The two things about, or the thing about methadone and buprenorphine is you really have, again, to have that plan, what happens when this patient is done with me in the hospital? Where are we going to? So that discussion really has to be had with them. Is this something you want to continue? Because otherwise we're setting them up for a detox. And detoxing buprenorphine is a possibility. However, it's going to take probably about a week to slowly bring them down safely. And then we still are going to need a plan for after detox. So a couple treatment options for opioid use disorders, and we can think about this as what is that plan for after we might see them in this post-acute crisis situation. They can go to self-help groups. I will tell you that in any substance other than alcohol use disorder, these do not prove to be successful by themselves. Interesting in the alcohol use disorders, self-help groups, fellowship groups, for some people can be as effective as any of the other types of treatments, but not for opioid use disorders. Detoxification plus MAT. Outpatient treatments plus or minus MAT, and then residential treatment plus or minus MAT. So a couple words about the treatment levels. This is from the ASAM criteria. That doesn't line up, I'm sorry. Preventative services are the early interventions. These might be needle and syringe exchanges that also do things like, lab tests for infectious disease. They might give alcohol prep pads for people so that they don't inject bacteria into their bloodstream and create endocarditis. So that's early intervention, but what they're also doing is they're introducing them to the idea that there is a safer way to inject as harm reduction. There's a safe way to reduce And then the end of it is that there's a much better way to be abstinent from those substances. So we've got 9 counties in Indiana that do have syringe needle exchange programs. And Delaware County is just in the very early stages of starting that discussion. I was just on a meeting yesterday. This is supposed to be pointing to level 1 outpatient treatment, but these are less than 3 times a week. Commonly, these are individual services, and so outpatient treatments would be like our OBOTs. We've got Sparrow Health, Groups Recover, Clean Slate here in town that are giving buprenorphine. We've got the methadone clinic, which is a very controlled environment for outpatient treatment. We are a level 2.1 intensive outpatient programming. We've got programming for 12 hours of the week. Partial hospitalization does not exist around here right now. Residential services are level 3s, and so there's low, medium, and high intensity, and they can be anywhere from 28 days to 90 days. To the VA program slowly brings people down over, in some cases, almost 2 years. If people are involved in the domiciliaries. And then there's the level 4, which is the medical hospital. So this is where my addiction consultation is at, where I'm seeing people who are medically abstinent. And so it is kind of a blend of treating their withdrawal, treating their addiction, but then also early intervention for a lot of these people because they did not intend to quit using at that time. It was something medically that caused them to do so. So let's get into the role of medications in the treatment of opioid use disorder. We've talked about a number of these and keep revisiting, but stabilization, reduction of withdrawal symptoms, opportunity to initiate or engage in addiction treatment. So that's kind of that early introduction to people and a lot of what I'm assisting with in the inpatient setting. Maintenance therapy. Of course, we can use that to eliminate withdrawal. Drug craving. Drug craving is a huge thing that keeps people coming back to their drug. And so if we can use something like buprenorphine to stop those drug cravings, then they'll be in a better place to actually engage in therapy treatments. And so that is one of the big things that we're doing with buprenorphine, blocking and attenuating the effects of heroin. And then harm reduction that reduces the risk of overdose. That is another big thing that we are doing with buprenorphine and methadone right now. So I told you we would revisit the 3 opioid addicted cohorts. And one of the reasons I wanted to do that is because I wanted to show you specifically, and it's a little bit more anecdotally because what I'm seeing are the patients that are in our hospital here, but we'll talk about the 3 opioid addicted cohorts in Muncie. There's the 20 to 39-year-olds. These are disproportionately white. Of course, we're in Indiana, so everybody's going to be a little bit disproportionately white. But these are opioid addiction that began with prescription use from family and friends, oftentimes in middle school. So it's something what we're seeing, all of these patients that we talked about with the addiction cohort, the 40-year-olds that were getting the prescription pills, it turns out they're sharing them with their family to some great degree. A lot of these people are being introduced to marijuana first, which also activates some of the opioid receptors, and that's the reason it's kind of considered that gateway drug. Smoking early on, a number of people will say that they get packs of cigarettes for their birthdays when they're in middle school or high school. And these are people who are often in families that it's normalizing the behavior of using these prescription pills throughout the family. Oftentimes these people will turn to injection of heroin or meth. Interestingly, heroin is the thing that a lot of people will prefer, especially when they've been introduced from the standpoint of starting with prescription pills. However, meth is a lot more predominant, and so what we're seeing is just kind of that substance of convenience, and oftentimes there will be things like fentanyl or a little bit of heroin mixed in with the meth, but they're injecting whatever they can inject. We talked about the cohort of the 40-year-olds and up that are on prescription pills. What we're really seeing here in Muncie is, again, disproportionately white, mostly started with RX opioids. but also found ways to get prescription stimulants, oftentimes by using their children's diagnosis of ADHD to obtain those medications, and then prescription benzodiazepines. The females particularly are either switched to injection at this point, sometime in their 30s, usually not 40s, but 30s, switch to injection by meeting a partner. Most women start injection by introduction from a sexual partner. Or a lot of times they're going the opposite direction. They're trying to quit. They have a lot of withdrawal. They have a lot of anxiety types of symptoms. And so they find a provider who's happy to prescribe them benzodiazepines just as long as they don't ask for opioids. So we are seeing a significant amount of that. It's not uncommon for us to see patients come over to the Addiction Hub who are very interested in treatment for their opioid use disorder or their meth use disorder. And then we look and we see that they've been picking up a prescription of 100 benzodiazepines a month for about the last 6 months. And they have absolutely no desire to stop that. Males, on the other hand, have been kicked out a lot of places. They often switch to alcohol as their main substance of use, but they are experimenting or using other medications when they can get them. These are also the ones who more likely will escalate the risk, so they'll start to increase criminality in regards to the way that they obtain things, or they might be the ones who are coming more often in to the different OBOTs trying to get buprenorphine that are then diverting it. And then we see the 50-year-olds and up. We talked about them starting as heroin users and continue to be heroin users. And what we see around here, we have 50-year-olds and up that are all now polysubstance users. They are mostly, or the non-white ones, predominantly used in social settings. And we see this in the hospital a lot more often with people who have alcohol use disorder, or they come in because of a cocaine issue. And then the white predominantly use in isolation. So much more sad, can't handle having friends around, I guess. But polysubstance users nonetheless, with the vast majority of people who have made it that long. So strategies for opioid treatment for all these people, well, they're not the same. We're not trying to get everyone to total abstinence. I guess that would be ideal, but we know it's unrealistic. So really there's two more lines of thought that are becoming a lot more predominant now. Harm reduction, of course, is the thing we're doing when we're treating people, no matter their situation, because they're pregnant or because they are a recent overdose. And then reduced use. Reduced use is something that we would like to see if we're talking about someone who has been in the hospital because of their particular use. So we're trying to reduce that use. We're trying to give them clean needles and education to really kind of control their use a little bit more until they're ready to potentially engage in total abstinence. And it's not that much different than the strategy we might use for pregnant patients who are having trouble quitting smoking. We try to get them to reduce that use in regards to their cigarettes. So I'll get into the treatment outcomes here just very briefly. We know that reduced overdose, methadone and buprenorphine, all you have to do is give it to people and suddenly we're reducing overdose risk by somewhere between 44 and 86%. And then reducing relapse, if we talk about 1 year of treatment, people being able to stay in treatment, methadone is kind of our gold standard there at the top. 50 to 80% will be able to stick around and stop relapse over that first year. Buprenorphine maintenance treatments is fairly similar to methadone. Naltrexone is not as good, oral in particular, because people just quit taking oral. But if we're talking about injection, injection has done a little bit better. It's important to talk about injectable naltrexone just because in Indiana, that's the only thing we can use in the jail population. Abstinence therapy, not great. Abstinence is not something that really should be primary nowadays. Even when patients say that that's what they want abstinence only. They've had a bad outcome with methadone in the past. Really, that should be investigated a little bit with them because they have a much higher risk for recidivism, relapse. And then detox only is also a very poor treatment method. You have to have a plan after detox with these people. And unfortunately, what we've seen with COVID-19, there are a number of large systems here in Indiana that have gone to detox only because they can still make the money, but it's a much reduced risk in regards to putting people inside of their program for 28 days. And so we've lost some residential treatment over this year, and they're just wanting to do detox with their patients. Medications for opioid use disorders. And so this will be very relevant in our last 10 minutes here for what you are doing. Methadone maintenance therapy. There's probably no one here that I'm talking to that's going to be doing methadone maintenance therapy, but it's important for you to understand what's going on. We have Muncie Comprehensive Treatment Center out on Briarwood. They are open. They are taking patients. They do intakes on Tuesdays, Thursdays, and Saturdays. And they are a very good option for someone who needs a controlled environment, but will not go to residential. So this is our best way to control an outpatient environment for someone. This is a full agonist that has a very long elimination half-life, although it's different for every person. It is a once daily dispensing. It reduces the euphoria of subsequent opioid use, so it's still dangerous if someone's using heroin on top of this, but oftentimes there's really not a reason that people would be because they're not going to get the euphoria from it. The typical effective dose, people are on 60 to 90 milligrams per day. Sometimes we'll see that even creep up higher than that. So if they're not able to be treated on buprenorphine and still having a lot of cravings, oftentimes we'll have to go to the methadone treatment center with them. And sometimes they'll be on doses as high as 120 milligrams a day. Contingency management, so people who do well can eventually earn the ability to take home doses. In COVID-19, something switched and people immediately started being able to take home a lockbox that had 7 doses of methadone in it for them. This worked out well for some people. This worked out very poorly for others. But nonetheless, that was one of the major switches with COVID-19. They also do buprenorphine at the methadone clinic. So just because you send them there doesn't mean that they necessarily have to do methadone. They can do buprenorphine at the methadone clinic as well. The one thing I would say is I put higher for pregnant patients. Oftentimes in that 3rd trimester or sometimes in the middle of the 2nd trimester, someone on a methadone treatment dose may need an increase in that towards the end of their trimester. And so if they're honest with you, they should desire to sign some sort of a agreement, release of information for you to talk with their particular methadone clinic and vice versa, so that you can discuss what you're seeing in regards to their withdrawal potential. Just real quick, the pros and cons. Increased retention in treatment when you're doing methadone, a lot decreased opioid use. One of the things that I like, it's a highly structured environment, and psychiatric comorbidity does well in the methadone clinic. You aren't scheduled a time necessarily to show up, other than the fact that you do have to get there before a certain time in the morning. This was often the gold standard for what's been studied in pregnancy. Some patients who have psychiatric comorbidity will actually get better with methadone without any other medication in the psychiatric realm. The cons, of course, are QTC prolongation and a lot of drug-drug interactions. Buprenorphine, something that you all are getting Data 2000 waivered for. Subutex, it no longer exists as a trade name, but that is the buprenorphine mono product. Buprenorphine naloxone, Suboxone is often what people refer to. But it's dosed in a 4-to-1 combination of buprenorphine to naloxone. It's a partial opioid agonist. It has that plateau or that ceiling effect. It does have a long half-life, not quite as long as methadone for most people. Typically once daily, but twice daily and 3 times daily dosing is safe. You do get some analgesic property from it. And so sometimes when someone has moderate pain, something that needs a little bit more than ibuprofen, it is safe to stretch out their buprenorphine dosing throughout the day so that they can get that benefit of the 2 to 4 hours of analgesia that you can get from it. So that is a very reasonable thing. The other thing is if you're giving someone 24 milligrams, maybe because they were a high heroin user, and they put all of that under their tongue, it's not necessarily going to dissolve all at that time. And so we often tell them, you've got to make sure each of those dissolves individually, or they're not going to get the full effect. And sometimes that's the reason people are on higher doses when 8 or 16 might do well for them, because they're not allowing that sublingual absorption. And they're swallowing, and then there's very poor bioavailability orally. So 24 milligrams is usually the highest effective dose. They do say you can go up to 32, but when you get to 32, it actually starts to potentially work as an antagonist and have some blocking properties. So 32 is really not a great dose to go to. I would stop at 24. It is less euphoric than other opioids. COVID-19, some of the things that changed, there was an emergency exemption. It's still in place where you can initiate buprenorphine treatment over telehealth. So the very first visit can be telehealth if it needs to be, because this is something that we recognize can be done as harm reduction, and very important. However, there was never any exemption needed for telehealth follow-up visits. So you can do follow-up visits with patients because this is a Schedule III status drug. Of course, you need a DEA waiver. You need an X license from the DEA in order to prescribe this. This is just to say that there's inhibitors and inducers that can change the buprenorphine a little bit, but not near as much as methadone. Down here at the bottom, I just wanted to point out that the mother study did use the mono product, buprenorphine only, not the buprenorphine naloxone. However, there's a lot more agreement now that there is no reason we have to use the mono product, and a lot of our pharmacies are actually starting to refuse to fill the mono product. So buprenorphine naloxone is very safe, we think, in pregnancy, and then naloxone is not bioavailable unless it's injected, and that's the reason the naloxone is there. Abuse and overdose potential, very low overdose potential. It's, as I just said, potential for diversion for sure, and that's why the naloxone product is used. Be very careful of people who are using benzodiazepines. It's no longer a specific contraindication to keeping someone on buprenorphine, but concurrent benzodiazepine use can create an adjuvant effect and create respiratory depression. And so then the buprenorphine, we lose the ceiling effect of that particular product with the mu receptors. This does create some issues with us in regards to its high affinity and slow dissociation. So anyone who's on buprenorphine may have issues with pain if they go in for surgery. And that's why we have to use formulations that have a little bit more lipophilicity, things like morphine, fentanyl, and products like Vicodin and Tramadol may be blocked completely by buprenorphine. So keep that in mind. If you've got patients that you're continuing on buprenorphine, you may need to start at something like a Percocet, an oxycodone, or more potent. Just to say that this is a real thing, and it's just because the net effect of the intrinsic activity of mu receptors is decreased. And so precipitated withdrawal can happen. It's very rare, and I've even found that some patients who are on heroin straight onto maybe morphine or other things in the hospital, even if I start at a very low dose, 1 milligram, 2 milligrams of buprenorphine, and work up over a couple days, they don't ever have any withdrawal from that. So some thoughts about that, but anybody who's ever had precipitated withdrawal, and ask your patients, they'll know about it. They will be scared about that. Induction, you learn about this quite a bit as a data 2000 waivered physician. They're asking you to do the CAL score. Someone who has a greater than or equal to 8 is perfect for that induction. And oftentimes they tell you to start with 2 to 4 milligrams in that first hour, take a look at them, maybe increase the dose up to 8 milligrams that first day, bring them back the next day, et cetera, et cetera. They might need some adjuvant medications if they're still having a lot of side effects. We do that occasionally with our patients. The reality of it is that most patients can safely do this as a take-home, but what we normally do is we only prescribe for a few days. We have them take, that 8 milligram tablet, break it in half the first day, do 4 milligrams, make sure that they feel better, potentially take the other 4 milligrams, have 8 milligrams the next day, and on the third day, have them use 8 milligrams and follow up with us in clinic. Because of the half-life, we want 5 doses over 5 days before we really see that full effect. But oftentimes we're looking to just put people on 8 milligram tablets. And part of that is because depending on their use disorder, 8 milligrams and above is actually the most successful. People who have been maintained on lower doses in the literature often have a lot more recidivism back to use. The reality as well is that pharmacies in Muncie only have 8 milligram tablets. So when we're trying to get into little doses, it puts a lot on the patient to try to split those and do a lot with those. Sublocade is something that we do at our place. And this is a good replacement for buprenorphine tablets for someone who is stable, though. This is not something that we would use in somebody just because they divert or their life is chaotic. This really only tends to work nicely in people who are stable on buprenorphine and don't want to keep coming in or taking a pill daily. Oh, I went the wrong way. So some of the pros and cons we just did. It is effective for pain on top of opioid use disorder. There's no toxicity to it. There is less neonatal abstinence syndrome compared to methadone that comes out of the mother study. The cons, one of the big cons, that can be diverted and is quickly becoming among the patients the new magic pill. And that's a little bit of editorializing by me, but what I mean by that is a lot of patients are using buprenorphine only and not really seeking therapy. And so we know that that starts as harm reduction for them, but they really then are only abstinent from their drug and replacing it with something else for a time period. And so they've never handled or dealt with coping skills or handled triggers and thoughts. And so it doesn't work magic for them forever. And what we find is that after about 9 months to a year, they often have relapses and they can't control those relapses. And we lose them for 5-6 months or so before they go back and they seek treatment again. So it is not magic, other than the fact that it is much better than their constant searching and using of heroin just to feel normal. And just a word about naltrexone. It is an injection. It lasts for 28 days. It's not as good in studies compared to methadone or buprenorphine. And many patients do disappear when they're not seen for 28 days for any sort of a treatment. So that's been our experience as well. But it is used in the criminal justice system. So this is my last slide, common pitfalls in primary care. Communication difficulties are one of the things that a lot of people have issues with. It's usually a lack of assertiveness or failure to gain trust. And I put that up there without saying provider or patient because that's on both sides. Patients don't often think that they have equal say in regards to how they're treated or what they want treatment for or how they see that treatment going. And these are where some of the ideas of them not liking MAT and feeling like they're going to be left on MAT. Failure to gain trust goes both ways, and so that's something that is very individualized per patient, and oftentimes it takes quite a few meetings with the patients in order to really get the full story from them. There are a lot of knowledge gaps about MAT. These are spread by patients to other patients, family members to patients, and oftentimes some of your ancillary support will have opinions about MAT that are often very wrong. Poorly controlled environments, and so this is where you have to set up the environment in your clinic in terms of how you do UDSs and what that means. Very often we see people using a urinary drugs or a urine drug screen, getting those results back and accusing the patient of having something in their system, or the patient feeling like it's punitive that they're having a urine drug screen. And so maybe they just bypass them in order to gain that rapport with the patient. These are all bad ideas because they really, for this particular treatment of addiction, what we're doing is we're just using those to kind of see how the patient's doing and whether they're getting better. And so there's nothing punitive about it at all. And if we really want to know what's in the system, we need a confirmatory test. And I would recommend this as well because, patients will have buprenorphine in their system, but when you send it for confirmatory, it might show you that it is buprenorphine product as opposed to the metabolite of buprenorphine. And so they might be a patient that's diverting your medication. That would be one reason that you wouldn't want to keep prescribing, even in a harm reduction situation, because that patient is demonstrating to you that their life is a little bit more chaotic. They're not ready for your level of outpatient treatment, and they should be referred on to something inpatient if they really need to start with something that's a little bit more controlled for them. Patient contracts often aren't followed very well, and then over-prescribing. So you're going to lose a patient if you jump them up to 30 days of prescription very quickly. They're going to take that prescription, they're going to disappear, and then they'll feel like they've burned a bridge and they won't ever come back to you. So over-prescribing means probably prescribing more than a week's worth at a time, and your patient's going to be on that schedule probably for quite some time. Some patients, maybe not around here as much, but or some providers will prescribe methadone. You cannot prescribe methadone. Well, you can if you're treating pain, but you cannot to treat opioid use disorder. Don't do it. The DEA will find you. Failure to address patients with pain. We'd love to not have patients with pain, but the truth is that the vast majority of patients that are using opiates for any reason, it's because they started with pain. Or any patient that's been on opiates for a long period of time will develop hyperalgesia most likely, so they will have pain. And so you have to talk about that and be very open and honest with them. You don't have to necessarily offer them anything other than multimodal pain treatments, but it's very important for you to have an open and honest conversation with them about that. And then the last thing I wanted to say was just underemphasizing behavioral therapy with patients. Behavioral therapy is the treatment. The drugs will eliminate the cravings, and behavioral therapy is what will help the patients cope with everything going on, and it's what will help them with the thoughts and the triggers. So I appreciate you all hanging on for the whole talk. If you do have particular questions, thoughts, comments, you are always welcome to utilize DiagNotes, with questions that you have. If you are trying to do an addiction medicine consultation for your patient because you have a little bit more complex patient, you have clinical questions regarding them, make sure that you talk to me, either DiagNotes or Paige, because it is a provider-to-provider service. If you just need transitions of care, we have peer recovery. We have social work, and they will help the patient transition care to a place here in town or a place nearby. And so those are certainly options for you. But let me know what questions you have, and I should always be available, especially during the work week, in regards to answering those questions. So thank you all again.